Please always consult with your physicians prior to making any changes to your treatment plan. Music is courtesy of Ryan Hamner. Welcome to Living with Scanxiety, the Cancer Podcast, a podcast geared to help you navigate the pediatric cancer world. As a mother of a child who battled a soft tissue sarcoma for over a year, your host, Rosaria Kozar, understands and will help guide you through your journey. She brings the knowledge of experts, families, survivors, and other organizations tied to the pediatric cancer world to your doorstep. Her mission is to inform, support, and promote hope for you and your family.
This is where hope lives. This is where hope thrives. Together as one.
But in kids, the most common tumor in kids, in pediatrics, is called retinoblastoma, and it's a white colored tumor. So when you take a picture and you see white instead of red, that's something that needs to be examined, soon. Now, the tricky part is that sometimes you can take a photo, and if you're just looking not in the right direction, maybe like in an angle, you can have not a red reflex, but that doesn't mean that you have cancer.
Hi, this is Rosaria, and I'm going to introduce you to a guest today. And actually, you know what? I changed my mind. I'm going to let him introduce himself. His name is Efren Gonzalez, and he works at Boston Children's Hospital. And he's just so versed in what he did that I'm so happy you could be on the show. So welcome, Efren.
Thank you so much.
Dr. Gonzalez, I'm sorry.
No, you can call me Efren, and thank you so much for inviting me to participate here. I'm very happy to help.
Oh, you're welcome. You're welcome. The pleasure's all mine. So tell me about you and what you do.
Well, I'm originally from Mexico, and I did my medical school in Mexico. And then I actually did a lot of training because originally I was going to stay in Mexico. So after my medical school, I did my training in ophthalmology, like to become an eye doctor in Mexico. And then for other reasons, like in life, I decided to come to the United States and do another specialty within the eye specialty. So I specialize in retina. So all the diseases that are inside the eye, like the retina is a small film that we have in the back of the eye inside, and that's what allows us to see. So I wanted to be a specialist on that. So I went to the United States, to Texas, and I trained for 2 years there. Then when I finished that, I really wanted to do like cancer in the eye, but it's one of those things that the retina specialists don't do because it's very specialized. So I went to Canada, and I was very lucky to be trained by one of the pioneers in cancer in the eye, especially in kids. And so I did another specialty there that is for cancer in the eyes for kids and adults. And then finally, I actually went to Boston. I came to Boston to Boston Children's, and I did another specialty in the eye that is only for pediatric for kids and for anything diseases in the eye for the kids. So I did all that. Now, to complicate even more things, because I wanted to stay in the United States, I have to do part of my training again in the United States so I can work here legally. And I have to go and do another, just pretend that I didn't do eye doctor. So I have to do another eye doctor specialty, which is another 4 years. So I did another 4 years. And then now I did everything, how it's supposed to be. And now I'm certified, and I have all the certifications to do that. So I have three subspecialties and 2 specialties in the same specialty.
I've heard that before. If you go to medical school outside of the United States and you come here, that you kind of have to go to med school again. So you experience that?
Well, luckily you don't have to do med school again. You can take this very hard test that they make us take for people who are from another country. And then once you pass that, but it's a long process. It takes like a couple of years, or maybe a year, a couple of years. And then once you do that, the government recognizes you as a doctor. So you don't have to necessarily go and do medical school again, because that's, 6 to 8 years. But then the fact that they recognize you as a doctor, that doesn't mean that you can work. Then you have to do training. And that's what you have to do in this country or within the, Canada or United States to be able to work, with all the proper permits and licenses and stuff.
Hmm. So the one that interests me the most and my listeners is going to be the one regarding cancer, where you were trained in Canada.
Well, all my training actually, all my training is for the same. Even though there are different subspecialties, everything goes and revolves in cancer. So all my specialties go and actually going for cancer. So right now, they hire me in Boston Children's, and I'm lucky to work there because it's a great place to be there. And I'm the director of the Ocular Oncology service for the past 3.5 years there. And I'm also the director of the Pediatric Retina Program there. And so my job is to basically treat all the cancer in the eye, meaning the eyelids, the surface of the eye, the inside of the eye, or the back of the eye. In kids, and I also go to another hospital across the street to Beth Israel Deaconess Medical Center, and I do the same for adults. So cancer in the eye for adults too.
I had talked to you before, and you said one of the things that's really interesting about cancer is when you take a picture, sometimes they have red eye, and then you can tell. Well, tell me about that again.
Yeah, well, okay. So I'm gonna tell. So there's many. Unfortunately, there's many type of cancer in our body, and in the eye, even though it's a small organ, it is actually, it has many layers. It has many different. Within the eye, there's many specialties. I guess we can say that. So, for example, the eyelids is part of the eye, and you can have cancer there. The white part of the eye, it's also part of the eye, like a cover. It's like a skin that covers the eye, and you can have cancer there too. Inside of the eye, where the color of your eye is, that can have cancer too. And then the back of the eye, like inside where you don't see it right now, you cannot see it with your own eye, with a naked eye. You can have cancer inside the eye. And then behind the eye, where the optic nerve connects with the brain, you can have cancer there too. So the one that you're asking me is when you take a picture or a photograph, or the flash, the light of the flash goes through your face and then through your eye. It goes through the color of the eye. So the light goes into the back of your eye and then comes out, and that's it's red because the blood vessels are the blood is red, so it's a red reflex. But when you have something in the back of the eye that it's not red, like a tumor, then you see the color of that, and usually they are white. Sometimes in adults they are black, and it's a melanoma of the eye, not the skin. It's very similar, but it's in the eye. But in kids, the most common tumor in kids, in pediatrics, is called retinoblastoma, and it's a white colored tumor. So when you take a picture and you see white instead of red, that's something that needs to be examined, soon. Now, the tricky part is that sometimes you can take a photo, and if you're just looking not in the right direction, maybe like in an angle, you can have not a red reflex, but that doesn't mean that you have cancer. Okay, so that's very important to know, because a lot of people will say, well, I just took a picture this morning of my daughter or my son, and it's not completely red. And let me tell you, it happens to me. Like, my wife told me one day, oh, I took a photo of Luciana, and it's not red, and I said, okay, but anyway, we're talking about really like a white reflex that is filling the whole eye. In those cases where, like, if somebody of your audience says right now, well, I have a photo where it's not 100% red, I would say, well, take another picture, take a few pictures, maybe tomorrow take another picture and see if it's really the same every single time, and as the patient or the kid or your daughter or son to look straight ahead and take a photo. Now, if it's really constant, that is white, then yes, I would say go to your pediatrician. He will know what to do. Or if you have an eye doctor, just go to your eye doctor, and and he will know what to do. But it's really important not to let it go, because even a few weeks or a few months can make a big difference.
Mm-hmm. And can you tell me more about that type of cancer?
Yeah. So retinoblastoma, it's is the number one intraocular, meaning inside the eye, tumor in kids. It is very common in the first 3 or 4 years of life. Okay. Now, that doesn't mean that after 4 or 5 years of life you cannot have retinoblastoma. we have actually a few patients that are, 9 or 10 years old, and they have it. It's very rare. It's really, really rare, but it can happen. It's extremely rare, I have to say. But in a young baby, meaning from birth to, to 3 or 4 years old, if you see something that is not 100% red, the red reflex, you need to address that immediately. Now, retinoblastoma not only shows with the white reflex. The tumor can also shows with other symptoms, like the eye can drift. So you can have your daughter look straight ahead, and one of the eyes is drifting out or drifting in. And that's one of the main signs that the parents notice sometimes, that they don't notice the white reflex, but they notice that the eye starts to drift. Mm-hmm. Yeah, either one or the other eye. Now, the tricky part for everybody who is in your audience right now is that, there's also a disease that is called strabismus. Strabismus means cross eye. That is normal and has nothing to do with cancer. Okay. Mm-hmm. So you can have strabismus, meaning your eye can drift in or out. And most of the time, the vast majority of the time, that is normal. That is, it's not normal, but it's the one that is not related to cancer. Okay. But there is one that is related to cancer, because the tumor is growing, so the patient cannot see 100%, and that's why the eye drifts. So I would say that as a pediatric ophthalmologist that I also am, the eyes can move weird or drift around or move funny in a baby up to 3 or 4 months of age. Okay, mm-hmm. Since birth up to 3 or 4 months of age, maybe 5, and you're pushing. If one eye moves all of a sudden to one side or to the other side, but then it comes back to the center, that's normal. That can happen because the brain is just new. All the connections are being formed, and that can happen. But after 3 or 4 months of age, if you're still drifting of the eyes are moving abnormally, you have to address that, because there's a big chance that either you have the normal non-cancerous variant that is called strabismus and can have consequences for your vision. So it's important to check it, but it's not a life-threatening condition. Or you can potentially have a life-threatening condition, which is a cancer inside the eye. So the good news is that our pediatricians in this country are awesome, and they know exactly what I'm talking about. They know exactly what to look for. So I would recommend your audience that, if somebody is drifting the eye after 3 or 4 months of age, just go to your pediatrician and tell him, yeah, he's drifting the eye. I just want to make sure it's nothing bad, and they will do a few tests in the clinic, and then the pediatrician will determine if you have to go and have an eye doctor examination. Okay, but I would say that if you see the drifting of the eye, and on top of that you see something weird like a wide reflex, a few things more than just the drifting, you should be very emphatic and make sure that they see you right away. Because a lot of the time, not a lot of the time, but a few times, they give you an appointment 2 or 3 weeks from now, and that's sometimes it's okay, but if it is cancer, 3 or 4 weeks can make a big difference. Mm-hmm. Okay, so your pediatrician will know if you say something like in the phone, I see a white reflex, or the eye is drifting and I see something white, or they know exactly that's a key word for them, and they will bring you right away. Mm. Okay, right away. When a pediatrician calls me saying I have somebody in clinic with something like that, I tell them, send them to me right now, like right now, not tomorrow, right now. Mm-hmm. So it's okay. I mean, sometimes they give you an appointment in a week or so, that's fine, but not more than that. And a lot of the times the pediatrician just catches this red reflex that parents don't notice it in the normal routine baby examination. So when somebody is born, they send you to the pediatrician, they look for all these things. So we're being taken care of by the pediatrician very nicely. But sometimes parents notice something, you're seeing your baby every day, and you notice something that is just not quite right, then you have to be more vigilant. And let me tell you something else. If you as an adult, you have the history of retinoblastoma, right? When you were a kid, you had retinoblastoma. maybe you don't remember, but you remember something that your mom told you, that you had something in your eye, or sometimes you actually have a fake eye, right? Because you had it when you were a kid. Then that's more reason to go to your pediatrician immediately, because then that can put you at risk. Okay.
Mm-hmm.
Now the good news for this is that there's treatment. 97 to 98% of retinoblastomas in the United States are curable, meaning that you will survive the disease.
Mm-hmm.
However, out of those 98% or 97%, about 3/4 of patients, we will be able to save the eyeball. Okay.
Mm-hmm.
A quarter of them, we may not be able to save the eyeball. And of the ones that we can save the eyeball, or those 3/4 that we can save the eyeball, a good amount, almost a little bit more than half, probably will have some vision in that eye. Okay. But certainly there's some patients that will not be able to have any vision in the eye, or we have to actually remove the eye, even though it's rare nowadays that we have to do that, but it can happen.
Mm-hmm. Does that depend on which stage you find?
That's correct. So
Okay.
as any other disease in the body, we always classify things, and we stage them. And cancer, we stage them. So there's many classifications for retinoblastoma. Many of them, there's one that we use the most, that is called the International Classification of Retinoblastoma, and it's basically a very simple way to stage it. We call it groups, and there's 5 groups: A, B, C, D, and E. Okay.
Mm-hmm.
Group A, it's a patient that has very tiny tumors that are super small, just only millimeters, and it's really, really tiny disease.
Mm-hmm.
And then I'm gonna go all the way to group E. That's a tumor that is filling the whole eye. Inside the eye is full of tumor, and then in between, from A to E, in between, group B has tumors that are a little bit bigger, but not half of the size of the eye. Group C are half of the size of the eye, and then group D are almost filling the whole the whole inside of the eye, but not 100%. So depending on what stage you are, then your treatment will vary, right? So in the first stages, like A, B, and probably some C's, you can preserve the eye. You treat the patient with laser treatment, with freezing therapy in the operating room. And some of them will need chemotherapy locally, but those are the ones who can most of the time can preserve good vision, preserve the eye. But then if you have a group D as David, or E as Edward, D and E, those tumors are very big, and most of these patients need chemotherapy. And there's many types of chemotherapy. Sometimes you have to put it on the vein, but sometimes, believe it or not, in the past few years, they developed a technique that you can put the chemotherapy directly behind the eye through one of the blood vessels. So you have to put a catheter into one of your veins in your leg, and then they put the catheter all the way to your head and behind the eye, and then just deliver the chemotherapy behind the eye. It's called intraarterial chemotherapy.
Wow.
And that's very incredible, because now we can preserve a lot of the eyes that in the past, and when I say in the past, I'm talking about in the past 15 years or so, we used to remove them. Now we can save them.
Mm-hmm.
We can save those eyeballs, so you can have your own eyeball, even if that eyeball doesn't see, it's your own eyeball, right? But unfortunately, sometimes there are circumstances where you have to remove the eye because the tumor is just too big, or it's a risk if you try to save an eye. So it's very important for the families that are listening to you right now that removal of the eye is not failure of treatment. It's actually another type of treatment, and it's actually very valid. And some patients need that because that's the safest thing to do. Okay. Mm-hmm. We are doing it less every time with the technology we have. We are doing it less and less and less to remove an eye, but we still need to do it sometimes. Okay. It is important to make sure that when you're diagnosed with retinoblastoma, they send you to somebody who knows about this. So usually there's 3 doctors that knows how to treat this. One is the pediatric ophthalmologist. Mm-hmm. The other one is the retina specialist, and the last one is the ocular oncologist. Those are the three specialties that I did. So I'm the three in one. But most people just only do one specialty. So either they are pediatric eye doctors or retina specialists or ocular oncologists. Sometimes you have a couple, but I did the three of them. So as long as you go to one of those, or even if you live in a remote area in the United States where there's no specialties, as long as you see an eye doctor, even if it's an adult eye doctor, they will know what to look for. And they will send you immediately to a center that is capable to handling that.
Mm-hmm.
Okay, but it's very important to follow the recommendation, because sometimes we have seen very sad cases where patients go, they are diagnosed correctly, and then it takes them a month to go, or they just I don't think the doctor is correct. No, he doesn't have any pain. There's no complaints, and then by the time they come back with complaints, now it's too late, and patients can die. The tumor can go, the retinoblastoma can go outside the eye, and that's very dangerous. It can go to the brain, and it can go also to your lungs and to your bones and other organs. And when that happens, the prognosis is very, very bad. That person is in a very bad condition, and we have to do many specialized treatments with chemotherapy, and sometimes you need radiation and other therapies to try to save the life of that patient.
Mm-hmm. I have a question. So when you're in the surgery room and you have to remove an eye, what happens? Who else is in the room with you? I mean, I know there's like an optic nerve that connects to your brain, but is it just like as easy as this is gross, but you take the eye and like, what do you do?
Let me tell you first. Before I tell you that, let me tell you. So when a patient comes to our clinic with an abnormal red reflex or a diagnosis of retinoblastoma, we see them in the clinic first. We do an ultrasound in the clinic, and the ultrasound can let us see inside the eye. Sometimes we can make the diagnosis right there and then, but sometimes we have to actually go and see it. Sometimes, as you can imagine, babies don't let us examine them, right? They don't stay still. But so most of the centers in the United States, after we do the first encounter with the patient, the next day or the next day or a few days later, we take them to the operating room to do what we call an exam under anesthesia. Okay. So the baby is sleeping, is not crying, is not upset, and now we can actually see very nicely the inside of the eye and really have a good idea of what's happening in that eye, because if it is retinoblastoma, we have to stage it, and because that will depend on the treatment that I was just telling you guys. And then, but to complicate even more things, because in life nothing is easy, there are some things, some diseases that look like retinoblastoma, but it's not a cancer. It's something else that is just benign, and it's not a life-threatening condition. So we have to make that decision to make sure what it is. Now, once we know or confirm that in the operating room, we send the patient for an MRI, sedated, also to make sure that the tumor hasn't gone outside of the eye. Mm-hmm. And then at that point, we talk to the medical oncology team and we say, okay, this is what we think it is. This is what the stage we saw in the operating room. And then we decide what is the treatment for that patient. Okay. If we decide that it's just laser, then I will just do it right there and then. When the baby is sleeping, it's just I put a device that is like a very fancy headband.
Yeah.
And then I, with that headband has a light and a laser, and it's like and then I see through a small lens inside your eye through the pupil. I'm not opening anything. I'm just looking through your pupil. And then I see the tumor, and then I with my foot I hit the button and the laser, and I start hitting the laser with laser, and I can see it right in front of my eyes how it's actually dying. Okay.
Oh, cool.
That's very nice. Yeah. Sometimes the laser it doesn't work, so I have to do freezing therapy that is called cryotherapy, and basically it's like a tiny pencil, and the tip of the pencil has it gets very cold, like frozen cold. So with the same headband with a light and my lens, I look where the tumor is, and then I put the tiny pencil outside the eye where the tumor is, and I hit the button, and then I can see through the even though the pen or the probe is outside the eye, I can see through the inside. I can see when the ball of ice actually starts to form inside your eye, and I can see how it's engulfing the ball of ice, engulfing the tumor. And now I know that it's frozen, the tumor is frozen, it's dying. Okay. Sometimes we have to repeat that many times. And most patients with retinoblastoma, we have to see them under anesthesia every month or every few weeks for a couple of years, every month, because new tumors can appear, the tumor treated can come back, or something else can happen. So we need to see them every single month until they are out of the risk, like when they are 2 or 3 years old. Okay. Now, if the patient needs chemotherapy, then I wake the patient up and I tell them, my colleagues, and I say, he needs chemotherapy. And then they go and do the chemotherapy. And then the next month I see them, and I'm going to look and see if the photo that I took before and the photo that I took right now after the chemotherapy is making progress. And then I can tell them, this is the only tumor that we can actually see with our eyes. Like inside the body, we only rely on MRIs and CT scans, but I can actually see with my eyes the tumor itself. I can see it, and I can see that it's smaller than before because the chemo is working. So I tell them, it's working, guys, let's keep doing it. And so that we keep doing it. Okay. Now, if we decide that eye has to come out because the tumor is just incredibly big, the patient is already blind out of that eye because the tumor is very big, and the tumor is putting his life at risk, then sometimes we decide to enucleate the eye. Enucleation means removal of the eye. Okay. So we talk to the parents. It's very hard because, as you can imagine, nobody wants anything removed from our bodies. But when you have kidney cancer, they have to remove a kidney. So when you have lung cancer, you have to remove a piece of your lung. Well, the eye is not exception. Because the option is that if you don't do it, then you can die. So we go into the operating room, as you were asking me right now. Usually, in most big centers, meaning big hospitals, we have trainees with us, which, by the way, it's something that we need to understand very well, because they're not just students, they are actually eye doctors. So when you see trainees in clinic, we call them, there's 2 types of trainees. They are residents and there are fellows. Okay. Residents are people who went to medical school and they're already a doctor, they're MD, they're already a physician, but they decide to do to be an eye doctor. So they are doing their residency, and it usually lasts 4 years. That's the one that I did twice. And it lasts 4 years. And then when you finish, you become an eye doctor, and you can do surgery. You can remove cataracts, you can put glasses, all sorts of things in the eye. You're a surgeon of the eye. But let's say that once you're an eye doctor, you say, hey, I want to be like Efren. I just want to do cancer in the eye, or I just want to do retina, or I just want to do glaucoma, or I just want to do cataract surgery. You can actually go and do another year or 2 years of training, and you become a fellow. Okay. So a fellow is a person who already is an MD. It's already an eye doctor, but now he decided to come and be just a tumor person like me. So he's just following me for 2 years. And he's becoming an ocular oncologist, or a retina specialist, or a pediatric ophthalmologist. So a lot of families said, "Oh, he's a student." No, he's not a student. He's an eye doctor. He's an eye doctor. He has credentials. He can do anything, But he is in training in this particular area. He's trying to be the best in this area. Okay. So when you're in the operating room and you're gonna do a surgery, we have trainees. So usually either we have a fellow or a resident with us, helping us, and they are learning, but they're also helping us. Now, it's very important to always be fair and clear with the families. We always tell them, Dr. So-and-so is going to be with us. The surgery, I do the surgery, but they help us. There are pieces of the surgery that they help us because we need to, I need help. And they are surgeons already, so they need to do those parts of the procedure so they can learn it. So do you want me to tell you about how do I remove the eye, or just who's in the operating room?
Hi, this is Rosaria, your host. I've decided to cut this episode short and put it into 2 parts because eye removal surgery can be difficult to hear when a child goes under anesthesia. However, it is extremely fascinating, and I just want to say thank you, Dr. Efren Gonzalez, for everything you've given us so far, and I hope that my listeners, you, tune into the next episode to hear more about what Dr. Gonzalez has to tell us.
Thank you for tuning in to Living with Scanxiety. Please subscribe to hear more informative discussions like today's. Music is courtesy of Ryan Hamner.